Good afternoon, ladies and gentlemen. I am happy to welcome you this afternoon session dedicated to early detection and screening of liver cancer that I will share with my colleague, Professor Moika Matici. The pathology community would like to highlight the need to better monitor people with liver disease, particularly with liver cancer, to ensure that liver cancer is diagnosed early. Professor Pierre Naon, expert on liver cancer from the Hospital Avicens in Paris, and a distinguished EASL member, will present why early detection and patient monitoring are key if he would like to see a change in the mortality rate related to liver cancer cases in Europe. One of the earliest parts of Europe's Betting Cancer Plan to be put into action was the commitment to updating the EU Council recommendations on cancer screening. We will discuss this and other opportunities at EU Council at EU and international level with three experts around the table. Dr. Barbara Kersten, head of the Unit Health Directorate, DG Research and Innovation, European Commission, and in charge of the EU Cancer Mission, and Dr. Partha Basu, head of a screening group on Early Detection and Prevention, International Agency for Research on Cancer of the World Health Organization. And also Mr. Pietro Fiocchi, MEP of European Parliament, will also give his opinion. Moika, over to you.
Okay, so thank you, Maria, and good afternoon from my side as well. It's with great pleasure to announce that as well during this second session, we gathered not only clinicians and policymakers, but patient representatives also to share their views and their worries. Indeed, to have a successful program, we need, if we do not take actions to address the challenges to early diagnosis, screening and treatments, and eliminate the gaps and inequalities to access to care in Europe, we cannot achieve our goals. So Mr. Korenyak, the president of ELPA, is going to present us some divisions in Europe between the West and the East. Mr. Miškovici will present us the efforts to overcome some great challenges in the North Macedonia. And we also have here Professor Maria Reis, a liver cancer expert from the Barcelona Clinic Liver Cancer Group in Spain, who prepared some good examples for us on collaboration at EU level and the Horizon projects. So Maria, over to you.
First, I give the floor to Professor Pierre Naon. He's going to talk about the importance of early detection of liver disease and patient monitoring for liver cancer. Pierre.
Thank you, Maria, for the nice introduction. Just want to make sure that you can hear me. Just give me a yes.
Yes.
And great. So it's a very big pleasure for me and honor to be with you today, because I think the goal of this presentation will be to highlight the strength of liver cancer surveillance and monitoring of patients with chronic liver disease, but also to highlight the caveats and limitations that we need to overcome together in the forthcoming years. And this will be hopefully the basis for our discussion later on. My disclosures and the next slide. So thanks to you this morning, my presentation will be simplified, because you highlighted both at the academic level, but also with the patient's representative, the whole picture of chronic liver disease, which will take decades for patients with the cause of liver injury to progress towards cirrhosis. So my presentation will be mostly dedicated to the state of cirrhosis, mostly when it is compensated and asymptomatic, because this is our angle to try to improve the early detection of liver cancer in these patients with the most severe form of chronic liver disease. And as you know, as it has been emphasized this morning, these patients have indeed two diseases. They have the complication of cirrhosis and also liver cancer, and also extrahepatic condition that explain why this is a so difficult cancer to treat. So next slide, please. I want to stress out with you that we have seen this morning also that there is a wide heterogeneity in terms of exposure to risk factors, lifestyles, and so on, worldwide and even in Europe. But I just want to take the time with you to see the curve, the survival curves of patients who have liver cancer, all stages connected. And you see here the black curves of European patients with cancer, which are between those from the African continent and Asian continent. And of course, we can understand that in high-income countries such as France, UK, Germany, and so on, we have a better prognosis as compared to African countries, but it is not explainable with other high-income countries in Asia, such as Taiwan and Japan. And what is the difference between these very high differences and huge differences of survival is because in Taiwan and Japan, they have massive screening and surveillance program of patients with chronic liver disease. This is a whole different culture as compared to Europe, and we should really take advice from these countries and promote liver cancer screening in Europe. So next slide, please. This is basically, I think, in my opinion, one of the most important way to improve the prognosis of patients, because I think we are all aware here and all agree on this different situation that when you detect a small liver cancer here depicted in the center of the liver, the patient will be eligible for curative treatment, such as, for example, here, ablative procedure by radiofrequency ablation. And your goal is, of course, tumor remission with a survival above 5 years. And this is in strict comparison with patients with advanced liver cancer, which are usually detected at the same time of cirrhosis. And these patients are only eligible for palliative treatment with a survival below 2 years. And what the main issue here is, for example, in France, we have 75% of our patients, HCC patients in this stage, advanced stage, because they were missed for the surveillance programs as compared to the other one with the small cancer. So next slide, please. So clearly, one of the focus I want to make today is the problem, the issue of the uptake of surveillance. And I was very happy this morning to hear a patient representative saying that they are aware. So I hope the patients also are aware of this recommendation of cirrhosis must be detected every 6 months using ultrasound. So this is a key issue here, and this is what we should promote. And I will talk to you about this in a few minutes, promoting to general practitioners and promoting to patients, and also hepatologists and gastroenterologists who sometimes miss these patients and do not include them in surveillance programs. So clearly, the standard of care for HCC surveillance is now widely adopted. So next slide, please. So the promotion of education to increase uptake of liver cancer surveillance is one of the major, the cornerstone for improving the prognosis of patients. And clearly, EASL have endorsed this recommendation. And clearly, the evidence of liver cancer is sometimes considered as low because it is not accessible to randomized trials. You cannot, some authors have tried to launch randomized trials proposing patients with chronic liver disease or cirrhosis to be randomized into surveillance versus no surveillance, but the patients refuse this trial. So we will not get this randomized trial as proof of level of evidence. But beside this, as you can see here, EASL have strongly gone beyond this low evidence and recommended liver cancer to be performed, and clearly should be endorsed by all government health policy and research agencies, as it had been advocated in the 2018 guideline from EASL. So next slides. I just want to just give you some examples of if how strong the evidence are, not on an academic basis, but on a clinical field. Here is the difference in terms of access to curative HCC treatment and survival between here an observatory study of patients with liver cancer in more than 100 hospitals in France, where you can see that only 20% of these patients were diagnosed during the surveillance programs, leading to very low rates of patient accessible to HCC curative treatment and only a 30% one-year survival. And if you compare in our country, the same country of France, a randomized trial which compared two different modalities for screening, you see here that patient had access to curative treatment 3 times higher rates and 96% of one-year survival. So clearly from the field, all physicians and of course patients who benefit from liver cancer surveillance agree that it is effective and should be promoted. Next slide. I want to highlight also the fact that the patient himself must be convinced that it is a lifelong commitment with his team or his medical doctor, because you see here in our French cohorts of patients with chronic liver disease, mostly from viral etiology in patients with cirrhosis, there is a clear difference of overall survival in patients who respected the 6 months time frame for liver cancer surveillance versus the other, and they have a double overall survival because HCC is detected sooner with a higher probability of curative treatment implementation. So again, we do not have strong evidence, but clearly from the field, from what we know from patients, what we know from cohorts of patients, clearly there is a marked effect of liver cancer screening. Next slide. So beyond these different caveats, I want to highlight probably what is the most important for academic teams that deal with liver cancer surveillance, which is the lack of sensitivity of ultrasound. First, we have the problem of uptake, the problem of surveillance, then we have the problem of sensitivity of our tool. And clearly, you know, as you can see here, only 45% of patients that undergo ultrasound screening will be detected with early HCC, which means that we miss almost half of patients. So we also have to improve ourselves in this field of liver cancer surveillance. Next slide. So this is probably one of the most important slides for this presentation that we have been advocated last year in Journal of Hepatology with Amit Singhal and Pietro Lambertico. How can we improve HCC surveillance? And this is the ideal, I would say, transition for our future discussion later on. Clearly, increasing surveillance uptake by promoting education of both patients and practitioners, and also improving compliance of patients are key to improve HCC surveillance results. And also the refinement of screening strategies by risk stratification of cancer and implementing new tools to improve the sensitive ultrasound, whether based on contrast enhanced imaging techniques such as MRI, and also early diagnosis biomarkers. So next slide. In the next few minutes, I will just highlight how this can be done, both on the field of patients and also in academic research. For example, here, if we want to promote new tools for HCC surveillance, we have to step into what we call personalized medicine, which is personalization of HCC screening. But we cannot do this for cost effectiveness issues in all patients with cirrhosis in Europe. We have to determine who are the patients that would benefit most from a cost-effective perspective from these new techniques such as MRI or biomarkers, and clearly launch randomized trials in this patient population according to HCC risk. Next slide, please. I just give you one example in France of one trial which should start early in 2022, and clearly which is dedicated to patients with the most, with the highest liver cancer incidence of above 3%, which are estimated at 35% of the French population with cirrhosis, and in whom we will implement ultrasound plus MRI in order to detect higher rates of patients with very small HCC. So next slide. So beside this promotion of academic research for improving early detection, clearly promoting patient education, awareness, and compliance are key, as I already mentioned. And you can see here, this is, for example, a study performed in the United States, where a mailed outreach for patients with chronic liver disease and cirrhosis were undertaken to sensitize, to help patients to improve their knowledge and the clinical pathways to get into surveillance programs. And clearly this works, but we have to understand now that it must be clearly be done on a higher scale, and probably at the European level would be fantastic to do this, to have automatic mailed outreach and recall procedures for these patients to stay into their surveillance programs. Next slide, please. So you can see that we have many fields of interest to improve the cancer. I just want to highlight that we also have, while doing this, to reduce the territorial inequity, which will be presented later on in this session. This is, for example, the difference according to your region in France. You can recognize here the region of Paris or the French Riviera, where you have a lot of doctors, maybe higher income, and you can see here that access to curative treatment in this region of France is directly correlated to survival. And it is, of course, the same in Europe according to income, or whether you are living in a deserted region of your country. Next slide. So in the few minutes I have left, I wanted to address another issue here, which is upstream of liver cancer surveillance, which is clearly the screening of patients with chronic liver disease. And I think this is the missing point that we have in clinical practice, because we saw this morning that access to the cause of liver disease, vaccination, we saw just one here that promotion of liver cancer screening are at the bottom and the end of the management of this patient, but we still struggle to find this patient, this asymptomatic patient with cirrhosis. So next slide, please. This is mainly the problematic of linkage to care, which is trying to find this patient in the primary care setting and helping them to come to the liver clinic to get into Ecdc surveillance program. So this is, for example, the example of NAFLD. We know that 25 to 30% of individuals in Europe have NAFLD. Of course, we cannot tell all these individuals to go to the liver clinic, but we have to have tools to detect some of them who will progress towards cirrhosis, then liver cancer, and this is how we will progress to fulfill what we call the linkage to care from primary care to liver clinic. Next slide, please. And for this, now we have tools, but they are difficult to use right now, and this is why we need to promote them. We have, as you know, what we call the non-invasive tools for liver fibrosis assessment. And you can see here that we have on the far right all the elastography techniques you can see here that are very expensive and costly procedures that are only available at liver clinics. But if you go back to the primary care, you can see that you have very simple algorithms such as the FIB4 algorithm, which mixes age, platelet counts, and transaminase, and can be easily used in primary care setting to detect patients with cirrhosis and then tell them to go see an hepatologist. So next slide, please. In my opinion, this is difficult to manage because you have to promote this to primary care providers and also help them, because it's a difficult calculation. You also have to need the help of biological laboratories to provide this, the result of this calculation directly, so the doctor can see, oh, my patient, my obese or diabetic patient may have liver fibrosis, so I have to send him to the liver clinic. And this has been endorsed very recently by EASL for the EASL guidelines for liver fibrosis assessment. As you can see here, this is exactly what I told you in the setting of primary care, or for example, in diabetology clinic, which is identifying patient with chronic risk of chronic liver disease and assessing this FIB4, for example, algorithm, which is free and easy to use. And you can see that you can very easily discard patient with a low risk of fibrosis, and on the contrary, perform some more sophisticated tests and maybe detect cirrhosis at the earliest stage possible, and this patient will enter surveillance program. So final slide, please. My next slide will be my conclusion, which I did as a drawing, as a cartoon, which is a call to multiple level action. And as I just showed you, I think that the primary care is probably where the unmet need is the most evident, where clearly identification of patients exposed to chronic liver disease, and among them, identification of patients with cirrhosis, is key to address the earliest possible this patient to the liver clinic. In the liver clinic, I think that promoting liver cancer surveillance, both at the patient and practitioner level, are also very important in the forthcoming years to make sure that we increase the rate of patients included in surveillance programs. And finally, in academic centers, as I showed you, improving the results of surveillance program using HCC risk stratification, more sophisticated biomarkers, or imaging techniques are also very important in this setting. So clearly, 4 words for me: education, compliance, promoting clinical pathways, and research are probably the most important words in this setting. And thank you for your attention.
Thanks a lot. Maika, do you like to introduce the next speakers?
Yes. Yes. So now here we come to the patient voice, and the next session is entitled Challenges in Screening, Access to Care and Treatment. It's time to reduce the inequalities in Europe. And the first speaker is going to be the president of the European Liver Patient Association, Mr. Marko Kuronjak, but he's also the president of the Slovenian Associations of Patients with Viral Hepatitis, Slovenia HEP. The title of his presentation is going to be very challenging: Europe divided to the east and to the west. So, Mr. Kuronjak, the floor is yours, please.
Thank you very much, Professor Matičić, for the floor. I should stress at the beginning of this talk a big thank you to Professor Matičić and her extraordinary engagement that this event is under the Slovenian presidency to EU. And I'm extremely happy to be right after the presentation from France, from Pierre Nahon, because the next president country will be France. So I'm looking forward to repeat this kind of event in France in next year. So yes, my talk is very challenging, very demanding, east, west, south, divided. There were a few things already said about division, so I will try to focus on the things that were not said and just go through things very quickly that were already addressed by distinguished speakers. So next slide. Just a short summary. So I will just present shortly who the patients are and what we do. Then we need to say something about the coronavirus response and the liver cancer patients' expectations regarding the coronavirus fight. And then we will go to some recommendations or things that we see it are important to include in the initiatives to better do the screening and testing and finding out patients who have liver cancer. So European Liver Patient Association is from 31 representatives from 25 countries in Europe. And we work very hard to provide help to patient organizations from different countries. Next slide, please. From different countries that are part of our organization. And this includes also liver cancer patients. Next slide, please. So with the communication with the medical field, we are currently involved in 10 different medical research projects, and you can see the logos here. And it's important to note that European Commission has said several years ago that end-of-the-line consumer or patient communities should be included into medical research projects for the increasement of the quality of the project, but also for the information to the general public, what is happening in this field and what are the advances in medical field that are beneficial to the patient communities. Next slide, please. So all of these projects are funded by European Commission. Next slide, please. So what have been seen from the patient community or the representatives of patients in European Union? So we saw a response from European Union that was devoted to the corona crisis that we are a part of now. So there were a few steps in this response that I want to mention now because they have a direct influence of the position of patients with liver cancer in Europe and how do we see it and what do we think it's an important part. Next slide, please. So one part of the response of European Union is to develop a new digital executive agency. And one part of the notion was that this executive agency will be helpful to rebuild a post-COVID-19 Europe. And from patient communities, we would like to be included in this process. We would like to be part of it. So one part we are already with the inclusion in the Horizon 2020 projects, but on the notion of inclusion, I should stress that, for example, European Medicine Agency has a special way of communicating with patient communities, and we want to see this happening also in this new European Health and Digital Executive Agency. Next slide, please. The second part that we saw is the notion of creating the European Health Emergency Preparedness and Response Authority. We do say as a patient community that this is important and it's a great step in the right direction. The COVID-19 crisis has also shown us the lack of trust in the work of European institutions. So we do think that if you include better patient communities or general public in the communication on developing communication strategies of these agencies, you will also increase the trust in these initiatives that are extremely important and really step into the right direction. Next slide, please. So we saw also that the European Commission has presented a proposal for expansion and reinforcement of ECDC mandate. So everything that was proposed is here on this busy slide, and I will not go into the details. I would like just to add something that is not there. So from the general public or from the patient communities, we think that ECDC should have a stronger role in advocacy level on the region and in advocacy level on a special communication in the national authorities. So we see this EU task force that will be assisting local response in member states as an important part, and we wish that the advocacy level of ECDC mandate here would be higher and would be also with direct communication to patient communities. Next slide, please. In a nutshell, so we think that we can better fight misinformation if we work closely together and if we try to develop communication strategies together with the new developed agencies and initiatives from European institutions. We need to try to work together because we expect that after this COVID-19 crisis, we will see the increase in number of patients, especially patients with problems with liver. Next slide, please. So we were addressing this several times today. So we have an elephant in the room, and the elephant is called the health inequities in the European Union. It does matter if you are a patient or liver cancer patient in Portugal or in Spain or in Germany or in Romania. You have different access to different parts of the healthcare. And together, I think that we will be working together to minimize this disparity. And we are looking forward to the solutions that we will bring to the table. Maybe next slide. So this will be my last slide. So the important three things that we think are important. So increasing funding for patient associations, patient networks in European Union, not just a specific funding for a specific cause, but to develop better networks of patients in European Union. So of course, we want to be also involved in communication with general public, where we think that with that, we will raise the trust to the European institutions and its work. And for the reshaping of European institutions, we would like to see patient engagement any way possible. The good examples are European Medicine Agency and also European Commission. And that would be all from my side. Thank you very much.
Thank you very much, Mr. Koreniak, for sharing with us the observations and the role of the patient organization in this field. And I'm sure that it's going to be discussed on our final discussion. And now I'm inviting the next patient voice. This is going to be Mr. Milan Miškovići, who is the founder of the Liver Center of Bitola, North Macedonia, and he currently serves as the organization's vice president and CEO. And Mr. Miškovići is going to talk about the example from North Macedonia. Please, the floor is yours.
Thank you very much, Dr. Mojca. I'd like to thank to all of you for the extraordinary work which you've done, especially for today. And this is amazing event where I can also the small one, middle income traditional countries to say a couple of words and the experience to share with all of our audience. Next slide, please. On the beginning, we'll say a couple of words about us, who we are, where we are. Hepatic Center Bitola is a patient association that celebrates its 10 years of existence. We are established to help raise awareness of infectious viruses and non-communicable liver diseases, especially hepatitis, NASH, NAFLD, obesity, alcohol use, and liver cancer. Hepatic Center Bitola aims to educate about and prevent liver diseases in different groups like youths, at-risk groups, and the general population. We're offering different kind of testing, screening, and counseling. We like to promote new solutions, different approaches for liver diseases, to protect the patient rights, to fight against discrimination, marginalization, and stigmatization in the same time. This is our main goals. Please, next slide. We see one interesting slide with pictures from idea to realization. I must tell you that when started the campaign about EU Cancer Plan, we have a couple of brainstormings with our president in European Liver Patient Association and some of the members how to proceed with this issue on the national levels. And we got one excellent idea how to proceed in my country, who is not still part of the European Union, but we are applicant and we trying to approach the European Union, but need to have some bigger or small changes in a lot of fields, also in the health. Please, the other slide. First step from our brainstorming with ELPA president and some of our members was how to gather all the relevant stakeholders in North Macedonia in one place, in one table, and to see what kind of challenges we have in this moment. We know that in the last 2 years, it has been a big challenge to organize any activities during the COVID-19, but our main goal was clear, and we put a special emphasis on the rooting all parties and stakeholders to get special attention for liver cancer as one of the proof of concept disease areas where personalized medicine and centricity for the patient will be explored. How did we do this when we know that the all health system in Europe and also ours in North Macedonia has shifted its capacity to COVID-19? We have several options. The first option was how we managed to have success was to the fact that the latest data on liver cancer, which coming out from GloboCan, was let's say very bad for us and for all community, and show that mortality has climbed to a height of place in the world, and that the biggest risk factors are chronic hepatitis B and C, NASH, obesity, and excessive alcohol consumption. Second option was the launch of the European Cancer Plan. We dedicated to change the approach this year and to prepare the first national declaration on liver cancer. Hepatic Center Bitola and ELPA managed to find a way through lobbying with the multiple stakeholders to assemble coordinated body working group with coordinators from all relevant health stakeholders, particularly from the clinics. I must say that the gastroenterology clinic was one of the leading clinics which support this initiative, and the main coordinator coming from this clinic, that is the director of gastroenterology. And the third part was an option how to bring and how to invite the Ministry of Health and all other relevant institutions like head into insurance fund, who give of course the possibility to fundraise about the program who will next be on our agenda. Next slide, please. After all our engagement together in all the important stakeholders in my country, we have organized 15 online meetings and 3 face-to-face meetings dedicated on the first national declaration on liver cancer from the beginning of May till the end of the July with the directors of the different clinics in my country. As a conclusion from the numerous virtual conferences, discussion and technical consultation, all participants from Republic of North Macedonia work on the first national declaration for personalized approach in the fight against liver cancer, in its prevention, diagnosis and treatment. This declaration is very important because we are calling our government in the Republic of North Macedonia, Ministry of Health, Health Insurance Fund, and all the affected parties to develop a full-funded national program that will be implemented through the partnership between all relevant entities and affected parties about in health and wider social context. I should be led by the European Commission on Parliament's development legislations and its health program, which expected to provide so-called wind in the back in the preparation of the dealing with the serious health threats and improvements in the fast recovery of the health systems too. Next slide, please. On this slide, you can see the signing of the declaration, all involved parties, and I must say that I have big gratitude also for the General Director of WHO Europe, Dr. Hans Kugel, who support us. This declaration was launched on the World Hepatitis Day, and I must say that Dr. Hans Kugel, particularly the past 2 years, is somehow like a wind on the back on our activities and initiatives in North Macedonia. Next slide, please. Also, in the same time, we have excellent promotion about the declaration to reach more audience, of course, to have, let's say, introduction to the general population in our country and all interesting parties to understand what we are trying to do. And we have a lot of media and online events, which ELPA President and WHO office in Skopje help a lot in this process, and also the directors and the clinics in my country who are deeply involved in whole the process. What was the big surprise for us was mentioned that we like to involve a lot of people from every kind of fields, not just medical experts. We got enormous support. I must tell you that from our celebrities from our country. We have celebrities who, let's say, spread the patient voice among all necessary groups, especially to the policy decision makers. They make a lot of interesting events, even in time with COVID-19, which give us enormous support. And this support was somehow raised on the national level to introduce all necessary stakeholders. Next slide. Finally, my last slide, I'd like to tell you that from our initiative, for the first time, we have a multidisciplinary approach in our country for patients. Need for care of most of the patients in the integrated multidisciplinary center. One of our desires from patient perspective was to open a special center for liver disease, a liver center within the Clinic of Gastroenterohepatology, which is now in the process of opening. I'm so grateful to our clinic and the main coordinator of the declaration. In the same time, we like to tell you that we started a study for early detection with our partners from Europe who support and give us some kind of donation for this study. And this study is starting in next Monday, I think. And what is most important, the declaration needs the most important stakeholders, collaborators and parties from all levels. The declaration started by strengthening the political leadership in our country. They engage young people and patient organizations to galvanize grassroots movements, fast implementation of the WHO, EU and scientific guidelines, which is necessary for this occasion, determination in dealing with the cross-border health threats, providing access to the necessary medication by making them available to everyone, especially need for personalized medicine, strengthening the national health system, digitalization, which is a huge, let's say, step and challenge for all of us, implementation of new methodology for monitoring and surveillance, implementation of national awareness plan, early detection, prevention, diagnosis, and treatment, And what is very important for us is the patient centricity, putting the patient on the first place, in open and sustained engagement on the patient to respectful and compassionate achieve the best experience and outcomes for them and their family. And what is interesting, there is no stigma, I must tell you, when we're speaking opening a special center for liver disease in my country. Why is that? Because all these patients with liver problems is going to be in one place, even the patient with the communicable disease like hepatitis B and C, which the stigma is, let's say, 100% is going to be less than last 2 years, because we are coming from the small, traditional, low middle income country. And that is our main goals. Thank you very much for your attention, and I hope so that you will have some questions.
Thank you, Mr. Miskovici, for this, for sharing with us your challenges and your achievements on the domestic podium. So congratulations for those, and wish you all the best for your future goals. And now, Maria, further to you.
Thank you. Thank you, Monica. Let's move to the next session that is devoted to the new cancer screening scheme and European Action Plan. And I would like to invite now Dr. Barbara Kerstien from the European Commission to present the cancer mission and how this initiative may help the implementation of European Vetting Cancer Plan. Thank you, Barbara.
Thank you very much. I would like to start by thanking the organizers for having invited me to present the initiative, the Cancer Mission. But also I would also like to thank the previous presenters for the enlightening presentations. On the one hand, bringing the science forward, the situation as it stands, and then two good examples of patient involvement and dynamics that can be created also to bridge the inequalities. Next slide, please. So you will have heard this morning about the Beating Cancer Plan, but under Horizon Europe, we have put forward missions, and I will just make a general statement on mission to start with. So mission is a portfolio of actions across disciplines intended to achieve a bold and inspirational, measurable goal. And you should achieve that goal in a specific time frame and with impact for society and policymaking, and should be relevant for citizens. And the missions that we put forward that have now been launched will support important Commission priorities, the European Green Deal, the Bauhaus Initiative, Europe Fit for the Digital Age, and, as of interest to you, the Europe's Beating Cancer Plan. And a mission contains a portfolio of actions that is not limited to research innovation actions. It can also be policy actions or even legislative initiatives. And these missions will help transform Europe, make it greener, healthier, and more inclusive and more resilient. Next slide. So the mission on cancer that was being launched is there to tackle the challenges that you all well know. 2.7 million people in the EU are diagnosed each year, 1.3 million die of cancer, and the cost of taking care of cancer is incredible. With the help of the mission board, a group of expert and patient representatives and policymakers, we have defined 4 mission objectives. Improve the understanding of cancer, why it develops and how it develops, prevention and early detection, diagnosis and treatment, and quality of life. And with the launch of the mission, we have put forward our ideas for the first 3 years of the implementation of mission, whereby Horizon Europe will provide about 400 million funding for the years 21-23. We are developing a strategic research agenda. We will deliver an Uncanny Understanding Cancer EU platform where we'll combine data from different nature to better understand the development of cancer. We want to put forward a Cancer Patient Digital Center, so a center where individuals, whether they are cancer patients or survivors, can get information about cancer, but also be helped in navigating the cancer care pathway. And then importantly, we would like to support together with the Beating Cancer Plan, the development of comprehensive cancer infrastructures. But importantly, why would we do all this? Because the goal that we've put forward is to improve the lives of more than 3 million people by 2030. And by working on prevention, cure, and for those affected by cancer, including the families, to live longer and better, and doing this jointly with the Beating Cancer Plan. Next slide, please. So the overall approach for the implementation, so the visual gives you the objectives, the goal of the mission on cancer and the pillars that we work on. But the overall approach for implementation is to apply the mission guiding principle. And one of these guiding principles is support innovation. Another guiding principle is to address inequalities. And a third guiding principle is to include patient and patient representatives, as well as survivors, family members in the design of the research. And then the research actions that we'll put forward, they should underpin and synergize with the cancer plan actions. And as I mentioned to you, the development of comprehensive cancer infrastructures or centers is something that is common for support, will gather support from Horizon Europe as well as from the Beating Cancer Plan. Now, we have putting forward a first work program, 21, with a total budget of 125 million euro. Next slide. And because this is about liver cancer and better screening, we will put forward specific research actions on screening and early diagnosis to help optimize and improve existing screening programs, but also, and importantly, develop new methods and technologies for screening and early detection, and also develop early predictors and tests. So for the scientific community, it is important to know that this will be put forward and could be of interest to you to apply. Next slide, please. Now, when we focus on screening and early detection, as you all know, the Europe's Beating Cancer Plan will address early detection through a number of actions, such as an update of the 2003 Council recommendation on cancer screening. So the Commission will make a proposal by next year, and it will make sure that it reflects the latest available scientific evidence on breast, colorectal, and cervical cancer, and to consider the extension of cancer screening to include other cancers if supported by scientific evidence. And that is important. And the Commission will base this decision on the work done by the Commission's group of chief scientific advisors that are currently looking into that question, the work of the joint research centers, and then outcomes of several EU-funded initiatives, and you see them on the slide. Next slide, please. And this is what I wanted to put forward. So patient involvement, addressing inequalities, a specific goal for the mission, and a focus on early detection and screening. Thank you.
Thank you. Thank you, Barbara, for working for the healthcare community and also for our patients. We hope in the mission on cancer in the future, liver cancer can be one of those that, together with colorectal cancer and other breast cancer and papillomavirus, could be included in the next year in the list. Thanks a lot for your presentation. Now let's move to the next presentation. I would like to invite Mr. Partha Basu, head of the screening group on early detection and prevention at IARC, to present the initiatives of this institution on cancer prevention and cancer screening. Many thanks for being here today.
Thank you so much, Madam Bhuti, for the kind introduction. Good evening to all of you. At the outset, I must thank the organizers for inviting me to this unique forum of experts, researchers, and advocates working towards prevention, early detection of liver cancer, ensuring the reduction in burden of the cancer and its consequence in Europe. The next slide, please. So what I will do in my presentation over the next 10 minutes is to discuss how best to incorporate or position the issue of liver cancer prevention and early detection within the framework of the new Europe Beating Cancer Plan, so that this particular issue gets its well-deserved attention and visibility. As you know, the Europe's Beating Cancer Plan is a wonderful, strong policy document, policy commitment that is structured around 4 key action areas. It takes care of the entire continuum of cancer care. And then this cancer plan is supported by 10 flagship initiatives, and each initiative is supported by supporting actions. So, for example, there is the plan to set up the Knowledge Center for Cancer, which will be, incorporated within the Joint Research Council, and they will have a major role in guiding the development of future guidance documents on cancer prevention, cancer early detection, quality management, implementation. So these are the examples of these flagship initiatives that are important for us to know and then understand where to start the discussion and where to bring in the issue of liver cancer prevention and early detection. And of course, as Dr. Carstens has already discussed about the Mission on Cancer, which is essentially focused on cancer research, and that's a wonderful opportunity again to address the issue. Next slide, please. Many of you must be knowing about the European Code Against Cancer. That is a project led by IARC along with other European partners. And it's a code or a message that is given to individual level on how they can best protect themselves against different cancers. And of course, in that message, in that existing code, there are already very key messages towards liver cancer prevention, limit or avoid alcohol intake, ensure vaccination against hepatitis B, avoid smoking or exposure to secondhand smoke, go for healthy diet. And I had a discussion with the project coordinator very recently. Now, there is already a commitment from the European Commission to go for the next edition of the European Code Against Cancer. And in that code, I think there is a unique opportunity to position the fact that improving awareness of the patients or the high-risk populations to go for regular surveillance is very, very important. So this is a great opportunity to bring in the message for improving the compliance of the patients to regular surveillance. And then, of course, there are other opportunities within the Europe Beating Cancer Plan. So, for example, there is a new project on improving health literacy on cancer prevention and care. There is EU mobile application on cancer prevention. So these are the opportunities we need to look at and see how best we can incorporate the right kind of messages. Next slide, please. And then these are, again, certain policy level actions that the Council has already committed to. They have committed to update the EU Council recommendation on smoke-free environments. They have already committed to strengthen the EU level regulatory instruments to increase tobacco taxation, and then going for increased taxation of alcohol, or even consider mandatory warnings on the bottles of alcohol. But then what is most important is for us to understand the value of strengthening the vaccination program. We know this is a wonderful tool to reduce the burden of liver cancer, and it has shown great impact in various countries. Even when we look at the European scenario, if you look at those graphs on the right-hand side, I don't want you to look at those fine prints, but essentially, if you look at the situation in Latvia, which is their second from the top in the middle, you see they have definitely achieved a great reduction in the hepatitis B incidence. But then still it started from a very high level and it still has a long way to go. And then all these issues around anti-vaccine lobbies and then anti-vaccine sentiments going around during the post-COVID situation, we need to be more careful, more vigilant to ensure that the vaccination programs are really strengthened. And then, of course, we need to strengthen the treatment of hepatitis C, which is eminently treatable, and then that can prevent many of the liver cancers. Next one, please. And again, going for European cancer beating plan, certain policies and actions that have already been proposed and can be usefully navigated to provide the appropriate opportunities for improving liver cancer prevention and early detection, is that there is a new European cancer screening scheme, which essentially is trying to improve the quality and coverage of cancer screening programs in Europe. As you know, again, the coverage of the existing cancer screening programs, which are targeting essentially breast cancer, cervical cancer, and colorectal cancer, is extremely variable across Europe. And then this particular scheme is aiming to achieve, ensure that there is a high coverage and then reduces the inequity that is already there. As Dr. Costain has mentioned, that the council recommendation is going to be revised. So already the scientific expert group is working towards that. They're collecting evidence, and then hopefully they will come out with this recommendation by next year. And no matter whatever we talk about prevention, early detection, again, a key component of the care continuum is to make sure that those patients with resectable liver cancers, they are appropriately managed. So the current commitment of the Europe Beating Cancer Plan is to ensure that 90% of the cancer patients within Europe, they have access to comprehensive cancer center or its network. So again, this is an opportunity to send the message that there is a big unmet need in terms of managing the patients who have early liver cancers. And then there are similar programs, flagship programs that are going for more personalized, more precision cancer early detection. So I'm sure there will be a role for that, as well as Professor Nahum mentioned, for some kind of risk stratified approach in liver cancer screening or early detection. Next one, please. Now, moving towards the core issue of screening for liver cancer. I mean, the decision for screening for any cancer has to be made very pragmatically. We understand that there is a need for every problem, but then also there are competing public health priorities. So one should look at certain issues that are important to make a decision. Number one, is this disease suitable for cancer screening? Of course, we have already heard that, I mean, nobody will argue that liver cancer is a major public health concern in Europe, and something has to be done. There certainly are tests that can help detect the disease at an early preclinical stage, and then treating those early preclinical cancers or resectable cancers does improve liver cancer survival. So there is evidence in terms of having appropriate, the requirement for going for screening. There are suitable tests, but then the cost effectiveness of that kind of approaches, whether we are going for alpha fetoprotein plus ultrasound, or we go for ultrasound only, or we make a decision for ultrasound based on alpha fetoprotein level. So all these issues, they need to be looked at from various perspectives. But again, cost effectiveness is an important issue, and cost effectiveness is not something that is common across all the countries. It is very context specific. So we need to look at the cost effectiveness of these interventions. But most importantly, which I'd like to focus a little bit more in my next slide, is the health system, looking at the health system. The next slide, please. So we know that the best impact of any cancer screening or early detection program is achieved if it is delivered through organized approach. What do we mean by organized approach? Organized approach means looking at the health system from the point of view of what we call the building blocks of health system. first and foremost thing, there should be a strong leadership and governance. So what we need to do for that, we need to have a policy framework, which already all of us today we are discussing in the context of liver cancer. But then only policy framework will not do. There has to be appropriate financial resources allocated either by the country or from the European level. Then an evidence-based protocol and guidelines will be required not only for screening, but then downstream management as well. And there has to be a well-trained health workforce to deliver all the services, including providing management of the screen-detected cases. Service delivery, of course, is the most key, but then within service delivery, we'll have to make sure that we take care of the entire continuum, starting from the improved awareness, how to invite those high-risk population that require the surveillance or targeted screening, what we call, and then making sure those who are positive are immediately taken care of. So for that, we need a strong health information system, and then a strong quality assurance of the entire program. So all these things, if we can organize properly, then if we then we can show that the liver cancer screening is evidence-based, and it does have an impact on survival, on the quality of life. And as I fully agree with Professor Nahum that many of the times we cannot come up evidence with randomized control trials, because in this kind of setting, the randomized control trial is no longer feasible. But then we also have to look at those pragmatic studies that are bringing in data from the real public health programs, and then see what is the benefit there. And before signing off, I will again point out a very important area that Professor Nahum has highlighted, that is improving our primary care facilities to be able to detect those symptomatic men and women who are at high risk of having a liver disease, and making sure that they are brought into the pathway of surveillance, the further diagnosis, and appropriate treatment. Then only we'll be able to reduce the liver cancer burden in Europe. Thank you very much for your patient listening.
Thank you, Mr. Basu, for this excellent presentation. Thank you for listening us. I think we are providing a lot of data that liver cancer is a public health concern that we can diagnose in a preclinical stage, and we have effective treatment available that clearly can improve the outcome of our patients. To finish this session, I would like to invite Mr. Pietro Fiocchi. He is member of the European Parliament in the Special Committee of the Betting Cancer Plan, and he is going to talk about his perspective of an MEP. Thanks a lot, Mr. Fiocchi.
Thank you for inviting me to this webinar on opportunities for hepatitis-related cancer prevention in Europe's Beating Cancer Plan, and especially for the session discussing liver cancer, early detection and screening. My name is Pietro Fiocchi. I'm a member of ENVI and ITRE committee, but especially I'm a member of the Special Committee on the European Strategy for Beating Cancer. I do apologize for not being able to be present, but I will send this message, and I will send all my availability and presence in your important battle. I completely agree that a very aggressive European strategy on early screening on all different types of cancer, not only liver cancer, but especially on liver cancer, is the answer. Now, we have seen the data from different member states in which they have different screening programs, and we do see the results. In the countries where the liver cancer screening programs are very aggressive, they do show extremely promising results. I will touch also other 2 points, well, actually 3 points, which are extremely dear to me and I think very important in the success of the BECA strategy. Number one is the formation of the EU database on all the oncological type of cases, but also therapies and results. This is quite a big battle because, of course, there is the privacy regulation which will try to stop this, but in my opinion, it's extremely important, especially on rare cancer. Number two, formation, education. It is extremely important to do education starting from the younger age, even in elementary school, regarding the correct type of diet on one side, but also behavior. Obviously, smoking, drinking excess alcohol, and so on and so on and so on is negative in regards to cancer. But in any case, the lifestyle is extremely important, and we need to educate our young ones since the start about what is right and what is wrong. And last is the post-therapy, because number one, we catch the cancer, we do the therapy, but it's extremely important in order to have good results to follow up with home care, rehabilitation, nutrition, and so on, and everything that comes with getting back the patient to a normal life. Because this is extremely important to have an extremely success rate in terms of patient wellness and habilitation. I thank you, everybody, and again, feel free to contact me for everything because I'm with you in this battle and I want to win the battle on cancer in Europe. Thank you.
Thank you very much, Mr. Fiocchi, for sharing the perspective of the member of the European Parliament with us. And now it's time for our last, but definitely not least presentation today. And it's going to be given by Professor Maria Reich, a liver cancer expert from Barcelona Clinic Liver Cancer Group Liver Unit in Spain. And it's always nice to hear some good examples. And Professor Reich is going to present us the good example of collaboration at EU level and Horizon projects. Maria, please.
Thank you very much for the invitation, and it's a pleasure to present good examples because I believe during the last 10 years we have a lot of collaborations at Europe and international level. Next slide, please. The first thing that I did is a search about the liver cancer at Cordis, and as you can see here, the next one. Perhaps, and could you put the next slide, please? We have several options at European level. 69 focus on liver cancer. However, when we focus on liver screening, the numbers are lower. Next slide, please. We have 4 options, for example, here of the 69 that we have in this regard. And the most important thing is only one was focused on children. It's important to mention that this disease is also in some children, but it is not the most frequent tumor in them. But the other point that I would like to emphasize at this level is the only one who have 26 centers this project in children. The other have only 2-3 centers. So in this regard, good examples not focus on screening, so it is an opportunity to work on that. And we need to consider the academic register that we have to explain the collaboration at European level. The next one, please. Here is a good example. It was done during the first wave of the pandemic. 66 centers around the world was participated in this study, but I would like to emphasize in Europe, as you can see here, 55 European centers were connected at that time. We did a survey about the impact of the COVID, the pandemic, on liver cancer, and as you can see here, 80.09% of the centers cancel the screening program. This is a huge impact for the next year. And the other important message for that study was related to the teamwork at that time that is also applicable on liver cancer. As you can see here, the oncology nurses were key members to transformation the face-to-face visit to the digital visit. So we are online at the European level in this regard. We need to have more and more data in this topic. Digital management of patients is something that we need to work on, but at least from the liver cancer field, we already have data in this regard. The next one, please. The other three examples that I would like to share with you are related to Ecdc. As you can see here, there are a network for 23 European centers, more than 1,000 patients. But the key message here is not the result of this study. The key message for this slide is a multidisciplinary approach on all of the study or academic registers that we have in the field of liver cancer. For example, in this example, hepatologists and statisticians were the leaders of this project, and that's why we have the result that we have at this stage. The second example, next one, please. It's related to another liver cancer tumor that is cholangiocarcinoma. This is the network that is called ENSCA, 34 centers from Europe. As you can see here, more than 4,000 patients with cholangiocarcinoma. And again, the leadership is not only for one group of physicians related to the disease, it's biochemistry, hepatologists, and biologists. And the last example from this slide, next one, is the other approach that is the register for this very rare tumor that we have in our patients, hemangioma or fibrolamellar Ecdc. And this is a project that started from EASL. This year, 2 of the grants from EASL are focused on rare tumors. And again, radiologists and oncologists were part of this project and they lead the project. So the key message for the good example that we have in liver cancer is the multidisciplinary team and leadership in this field. The next one, please. Next one. However, when we talk about cancer, we are faces, as was presented in the previous presentation, that we have 2 streams of patients, those who have at risk of cancer, developed cancer, have the chance, for example, liver transplantation. In this network, the liver transplantation center, they also were very well organized. Here we have an example from another type of initiative from the associations, ELITA, EASL, and ILTS, with a survey for these 470 centers. However, only 29 from Europe. On the other side, we have those patients who have advanced Ecdc or who have some specific disease such as dialysis. And that's why I would like to show you also a good example for this very few number of patients that also have the disease, but we do not have information from randomized clinical trials. So the next slide, please. The next. Here is an example for academic research for 44 centers around the world for only 22 patients who presented advanced Ecdc and dialysis. This group of patients now have also information about the safety of specific treatment. It is not important the treatment that we evaluated at that time. The idea is to show how do we organize to have results for all patients that have liver cancer. The next 2 slides, please. And this one, the last one, is another example for patients who presented advanced Ecdc and also had prior history of liver transplantation. This is a very special population, as you can see here, 28 centers, 28 patients. That means 1 patient per center, but we also have the capacity to organize the center, the physician, and have results for these patients. So the key message for this slide, it is not only important the incidence of the disease or the profile of the patient, we need to be connected to have results for everyone. And the last slide that I have, please. The last slide is a good example. How do we extrapolate all of this idea in screening? The next slide, please. As we mentioned before, we have a population at risk. We also have some tools for screening, but we need to improve. Why? Because we know that the patients improve their overall survival if we focus on that patient who are really at risk of liver cancer. The next 2 slides, please. So here I'd like to finish my presentation. How do we improve at liver cancer screening and diagnosis at the European level? I believe that based on the experience that we have in coordination between the specialists that really involved in that, education for patients to be confident for the screening, and also optimization of the human and healthcare resources. So I'm very happy to listen to the previous talk from Professor Basu, because we are exactly in the same line. The good results were based on this profile. And here's the example. Search's project was a screening program with adherence as 96% at first year, 80% also during the pandemic, and all but one patient presented a more than very early Ecdc. So the key message here is the coordination, where the nurses are involved in liver cancer, increase the adherence of patients. And again, the hepatologists, radiologists, pathologists, or teamwork is the key things for a good example, at least in my point of view. So with this slide, I would like to finish, and thanks again for the invitation.
Thank you so much, Maria, for this excellent overview of research that is going on in Europe, and the collaborations throughout Europe. They really look amazing and very optimistic. And of course, they'll be very important for expanding the carcinoma screening scheme, as was already said by Barbara Kerstiens and Dr. Parta Basu. So Maria, now over to you.
Thanks a lot. It's time for the Q&A session. I would like to ask the speakers to open the camera. And there are several questions. Let's start with Teresa Casanovas. Teresa, please go ahead with your question.
Teresa, you're on mute.
Yeah, so if there is, in the meantime, let's start asking a question to Pierre now on. What are the barriers for identification of cirrhosis in primary care at a population level, and how could they overcome? Pierre, could you comment on that?
Yeah, that's a very good question, Maria. I think I showed you that this algorithm that can be used in primary care are easy to use but complex to calculate, and this is one of my I would say question is and can be answered by some other members of the panel. We must be convinced first that it is useful for the patients, so we must convince biologists to automatically calculate this algorithm and provide it to the general practitioner, so he doesn't have to think and calculate this algorithm. And when he received the results of the laboratory, this is a very pragmatic question. He has the result and he says, oh, you have diabetes, but you may also have liver fibrosis, so go to the liver clinic. And this is how we can have, and I really enjoyed Parta Basu slide showing the complexity of framing of this intervention, because we are convinced as doctors, we can easily convince other doctors, but as a community, it will take a lot of time and action to put in clinical perspective. So clearly, this is why we need politics now. It's not a matter of science, it's a matter of politics, and let's go for it. But it takes time.
Thank you, Pierre. Mr. Basu, do you like to comment on this, or do you like to add your point of view?
Thank you. I think that's the most important issue to be settled at this point of time. I mean, we all agree that there is a good test. It does, improve survival and then quality of life, and it may be even cost-effective in many settings. But most important thing is the implementation challenges. And the implementation challenges, when we're thinking of barriers, we think of at 3 levels. First, what are the barriers for the patients or the population, general population, to access care. Then what are the barriers at the level of the primary healthcare providers? Maybe the primary healthcare providers, they are not trained enough. They have never been exposed to see a liver disease. It's quite possible, because some of the primary care, we have to understand, they see a variety of patients, which is a very mix of all kinds of diseases. So from the perspective of the provider, there may be some challenges, but most important challenge is the system level challenges. System level challenges is like, if somebody does have a problem, do they know where to go? I mean, is there an appropriate opportunity for that person to reach the appropriate hospital, which will be providing appropriate guidance on the liver disease? Or if somebody is already having a liver disease and requires appropriate surveillance, is there a structured surveillance mechanism available in the country or the area? So we need to think of all these three aspects, and a good barrier assessment study is always very, very valuable to understand this, which does not require much of resources, but then one has to look at all these aspects. Thank you.
Yeah, thanks. I think we have these tools, but probably we can increase awareness and education and spread the tools that we have. Now let's move to Teresa Casanovas. Are you ready, Teresa?
Thank you. Yes. I would like to announce that the next 26th of October, next week, ELPA, joining with DICE, which is an association of digestive cancer in Europe, is launching the white paper on liver cancer. This is an important document, not only from the point of view of the scientifics, but for all the citizens in Europe, because this is a document comprehensive with all the assessment and possible solutions in each step of the process of liver cancer. Thank you.
Thank you. Thank you, Teresa, for this comment. There is a question from the chat, just to mix live and chat question about if there is any collection of consolidated statistics regarding liver fibroscan by anyone, anywhere, that can then be analyzed by country, region, age, gender results. Perhaps Pierre or Maria, perhaps one of you can answer this question.
I am not aware of any efforts, at least at the multi-centric or European efforts, but this kind of databases. Mostly you have cohorts of patients.
It's difficult to hear.
Yeah, you hear me?
Yes, yeah. Better.
I am not aware of multi-centric efforts at the European level on this matter, but you have several cohorts in different countries that can be accessed. So Maria or Reg, if you have any comment for this.
Yes, I believe that at this day there are not a final result for any of these collections. This is a European project that it could have this information in the future, but it's not available at this day, at least from my point of view, or my know.
Thanks. There is a question for Milan. It's regarding the patient representative, and the question is about why do we need patient representative, caregivers and care managers to be involved in all the process? What is the role of the patient representative? And I think Marco also can ask this question if he wants.
Thank you very much for the floor. Yes, I think that throughout this all presentations today, it's clearly, and especially from Professor Basu, it's clearly noted that we need all stakeholders at the table, and we need the will of the recognition of the general public that this is an important issue, and we need to solve it on the systemic level, because the evidence is here, the doctors are interested, so the patients are interested, so we just need the next step, and the next step would be to involve the people who are really making a decision, as we are doing now today.
Milan?
Thank you very much, Dr. Maria. I have a question to Barbara. How you notice we have dedicated in my country for early detection. My video, sorry. Early detection was the primary goal in our declaration, and we started with a study, and we like also to see the opportunities now around Europe to find the partners also who are prepared, especially from the European Union countries, which will do something similar, and to compare all the results maybe, and to find out where's the biggest burning gaps in the early detection. This study is already supported from European Liver Patient Association and some other European stakeholders. But my question is to Barbara, do this kind of initiative through the Horizon program can be possible to be applied and to find a way to together with EASL, like one of the biggest scientific community in Europe, to find, let's say, bigger impact to the early detection in the next period, because if we know that COVID-19 situation is still ongoing, that means that we will have problems.
Thank you for that question. And before answering your question, I just wanted to react also on the question on the importance of patient involvement or patient representative involvement. There are two. First of all, it's important to know what matters to patients, what is acceptable to patients, and what is desirable from people that not yet have cancer, in order for them not only to be able to make themselves available for a screening program and understand the importance for it. So there are very different reasons why patient involvement is important. You all know about research that was robust in terms of science, but not really, the results were not applicable because, for example, the technology developed did not meet the requirements of the health professional, for example, the surgeon or the radiologist. So getting the end users involved in the design of the research is important, and getting the end users involved in awareness raising, it improves the quality of the awareness raising. So and that's why also I pointed out that for the missions, we really make this consistent effort to involve patients in the research, in the monitoring. And I also wanted to all of you to make you aware, I assume that my colleague John Ryan this morning made reference to the stakeholder platform that has been set up for the Beating Cancer Plan and the mission. So there you can register and participate in events. And then to come back to the question on the research opportunities. So there we have funder and tenders portal. That is what is where you can see the research that will be published, the topics that will be published, but you can also look for partners. So there's a facility where you enter your name, the research you're interested in, and then you can look for additional partners. So that usually works well. And I also wanted to say that in terms of the governance of the mission and the Beating Cancer Plan, there's the SGPP subgroup where you have representatives from different ministries participating. So you can draw your attention to that. Thank you.
Thank you. Thank you, Barbara, for highlighting the importance of the patients' organizations and the patients' representatives. Following with this, I would like to ask, what are the gaps that you can see in the liver cancer program? And this is a question also for you, Barbara, and for Mr. Basu.
I think, and that's why I was referring to, we realized that with the new technologies developing, that there are probably new methods that need to be developed to make the early detection of cancer in general and liver cancer in particular more efficient. And in parallel, I think this was pointed out by several of you, we need to work on the implementation of the screening programs that could exist, because there's knowledge there, things are feasible, but we need a combined effort to be able to implement the screening programs that have been identified as good screening programs. And the other point that I want also to draw your attention to, but you're fully aware of that, is of course that it's the member states themselves that decide on the way they will do screening at the health, either through a full-blown screening program or through individual health professionals participating in screening programs. So there's a responsibility, there's also advocacy to be done inside your countries, and I think North Macedonia is a good example of how things can be changed when you work at both levels, if you will.
Parta, do you like to add something?
Just to add, that what we learned from Europe and in implementing colorectal cancer screening, breast cancer screening, or cervical cancer screening is the importance of doing pilot. We don't make a decision overnight to go for a screening program throughout, say, for example, France. We need to do a piloting in a small population, learn lessons from that, and then think of expanding in a stepwise manner. So I think that kind of mindset setting, and then that kind of thinking will also help when we are thinking of liver cancer screening of the high risk population. Go for a pilot, and then learn lessons from that, implementation lessons, and then think of expansion.
I think Pierre wants to do a comment, and I think also you can ask the question from the chat about MRI as a tool for screening, or what will be the best tools currently available for screening. Pierre.
Thank you, Maria. Yeah, I wanted to respond and comment with you, Dr. Basu and Dr. Castians, about this implementation of new technologies to improve screening, as I showed you. But you partially answered my question, which is, should we first begin with national projects, then go to Europe, or should we already launch large trials? Because the caveat here is takes time. If you want to meet an endpoint, which is basically, for example, as I showed you with MRI, what we are conducting in France, it will be a 6 to 8 years time frame to complete the trial. And so hopefully, if the trial is positive, go to Europe to confirm the results. Or should we already, as a European community, launch dedicated programs to improving liver cancer surveillance? So what is your what would be your advice on this? Just working on each different countries, then come back to Europe, or already launch a very large and ambitious project to improve surveillance programs? What is your opinion for this?
Dr. Castians, would you like to go first? Okay. When we are thinking in terms of bringing in some new strategy, both aspects are important. One, as I said, about piloting the intervention. I mean, when we say piloting, we pilot with what we have. We don't think of bringing in new things, or we pilot with where we have already evidence that it has worked, it is feasible, it is acceptable. And then we do the pilot, and then we learn about the implementation challenges. But parallelly, it's also important to continue and support research, as you said. Maybe at some point of time, we will have an even better tool that will help us to shift from one type of intervention to another type of intervention. Just to give you a classic example is that, cervical cancer screening went on for so many years with pap smear cytology. It did work. It's not that it didn't work. It did work. But then when we came to know that there was a much better test, which is HPV detection test, is available. And then you see gradually all the countries are transitioning. So it's medical science is very dynamic. We learn as we move. That doesn't mean that we stop and then just say, no, let us wait for 10 years for another randomized control trial to come up with results. So that will be my response to you, Pierre.
Yes, and if I may come in, indeed, like Parta was saying, there's a difference between implementing a program based on evidence that exists, and then it's better to start as a pilot. Does it really work in practice? And the research that provides the evidence is saying this could work. And for the research, it's true, like you were saying, it's like for rare diseases as well. If you can work across countries, your recruitment will be more efficient. So in that sense, working at the European level for the research makes sense, because you can gather the necessary evidence for your trial more quickly than if you do it in your own country alone.
Maria, you have shown that we can work in European level. You have provided some examples. So Maria, can you tell us what are the gaps and how to overcome these gaps, particularly for implementation of the surveillance?
Yes, Maria, my comment and I also answer the question is in this line. I believe that for screening, we already have the data, and we know that it's not possible to improve the evidence that we have at this day. So the key thing is the implementation, and that's why I finished my presentation with the SEC project, that is a screening program where we decided to change the strategy, because we know that the patients know that they are at risk, we know that the physicians know, but we need to improve the adherence for that, and to also engage the radiology to perform the ultrasound with the quality that we need. And that's why we consider the nurses as the key person for that. The patients are more confident with patients, they are close to them, and I believe that the gap is implementation and restructure the patient journey for implementation of the screening. This is my personal point of view.
Thank you. I think this has been a great discussion. We have discussed that we have the tools available, but we need to increase awareness. We need to increase education, collaboration, and probably all of this help in implementation of the surveillance, that at the end it's the key issue. I would like to pass the micro to Thomas Berg to close the meeting and to give the summary remarks.
Yes, thank you very much, Maria. Perhaps you can open my video. It's still blocked. And I think I will hand over first to Marco, who would also like to give some concluding remarks, and then I will follow.
Thank you very much, Thomas. Yes, just a brief thank you to all the participants, all the panelists. A big thank you also for Slovenian government to show us that this is an issue that is of an interest of the highest level of European Union, as Slovenia is the president's country now. I wish to express also thank you to Professor Buti, Professor Maticic for the excellent second part of this meeting. And I do hope that we will meet regularly and measure the results that are definitely influencing the liver cancer patients in Europe. Thank you very much.
Yeah, thank you, Marco. So coming to my concluding remarks, and of course, first of all, I really want to give my special thanks to the Slovenian institutions, and here especially to the University Medical Center of Ljubljana, to you, Mojca, to the Slovenian Society of Infectious Diseases, and a special thank really to all the representatives of the European institution and the WHO for their support. A special thank also to the courageous patients advocates who carry their concern, sometimes also, a very important voice, as we all are aware. And then a special thanks to all colleagues from ELPA, to you, Marco, the president of ELPA, and all colleagues from EASL for their commitment today and every day, and especially to you, Maria Buti, our head of the Public Health and Policy Council. So what to conclude of this high-level event? And I think we have clear evidence that liver cancer numbers are increasing. But what the meeting showed is that there's also evidence that both prevention and early detection of liver cancer is feasible, and not only feasible, but can be improved. And I think liver cancer may even serve as a model for cancer prevention strategies in general. It's not unlikely that prevention measures that primarily target liver cancer can be associated with a reduction in the global cancer risk because of the common risk factors. And the magnitude of this effect may perhaps be greater than we are now realizing. So with the help of all of you, all stakeholders and partners with whom we are gathered here today, liver cancer prevention, screening, early diagnosis, but also improving inequalities in care of patients with liver cancer in the EU can become a reality. And I would like to name it the hepatology community with EASL, ELPA, the patient community, their families have not only the tools, but also the will to make this reality. So to conclude, to save lives, we really need to push for the updated Council recommendation on cancer screening to also include liver cancer. The current draft report of the Beating Cancer Committee on the implementation of the Europe's Cancer Plan recommends in its amendment 623 that member states roll out quality assured programs for early detection also of liver cancer. And this is really a big success, and we thank to all those who have contributed. However, we must double our advocacy efforts and make sure that these amendments stayed in final report. I thank you all, wish you a good day, and hope to see you soon. Thank you very much.